Yeah, I think the biggest thing is being able to identify and diagnose psoriasis in kids. There's this misconception that kids don't get psoriasis, and I can tell you they definitely do. And we're seeing it with increased frequency. And so much of the time, psoriasis in kids ends up getting misdiagnosed as other things. Now, that happens a little bit more in the primary care world than it does in the dermatology world, but I think it's still important to understand that psoriasis in the pediatric patient population is something that's out there. It is increasing in prevalence, and it's important to initially recognize that that is what it is. And then it is appropriate to start topical treatment, which largely consists of topical steroids. Sometimes we will use topical calcineurin inhibitors for sensitive areas like face and folds. And we have a topical non-steroid called roflumilast that's approved to treat pediatric psoriasis for patients age 6 and up. That is a once daily application. And so that's a nice option. That's still a relatively new option. Now, if topical medicines are not enough, I always encourage audiences to not be afraid to treat kids with bad psoriasis. We've got 4 FDA-approved biologics for the pediatric patient population. They include etanercept, ustekinumab, secukinumab, and ixekizumab. And we also recently had the approval of apremilast, which will be the first oral medication approved for the pediatric patient population with psoriasis. So we have options in these age groups, and kids deserve great medicine too. They deserve to live a life that isn't saddled with the burden of psoriasis. And we know that psoriasis has numerous comorbidities, and we think there's a chance that if you treat with a systemic agent that you are perhaps reducing the risk for those comorbidities. And so we want to do our best for our patients so they can live the life they're meant to live. Yes. So I talked about tinea faciei, which is a fungal infection on the face. And I mentioned that there's kind of a motto in pediatric dermatology that an asymmetrical pink scaly rash on the face of a child is tinea until proven otherwise. And I shared a couple pictures of relatively subtle rashes on the faces of kiddos that meet that criteria and are tinea faciei in an effort to kind of illustrate this point and get patients on treatment early on. We know that we need to treat fungus on the face and the scalp with an oral medication rather than a topical medication. Occasionally, if you catch tinea faciei super early and you promptly treat it with a topical antifungal, occasionally that can be effective, but more often than not, the fungus has dove down into the follicles, and so a systemic agent is necessary to treat it. And we talk about terbinafine and griseofulvin as our 2 major options to treat tinea faciei, and they both have their advantages and disadvantages. Griseofulvin is available in a liquid, so that's nice for kids. It's in a liquid. It does have to be taken with fatty food to enhance absorption. It is twice a day, and the treatment course is a bit longer than with terbinafine. Treatment course of Griseo is usually somewhere between 3 to 9 weeks of treatment. You never have to worry about doing labs with Griseo, and so that's nice too. Terbinafine is once a day, but it only comes in a pill. You can have a liquid compounded, but that can add cost to everything. It is a shorter course of treatment, typically 3 to 6 weeks. You do have to at least talk about labs. We don't consider blood work necessary in our pediatric patients because they are not drinking alcohol. They're not on other medicines metabolized by the liver. They haven't had time to get a fatty liver. So normally we don't feel labs are necessary in our pediatric patients, but you do at least have to talk about it with the families because they'll Google it and see that, often we do labs. And so you do want to at least talk about that. I talked about treating tinea capitis and how, again, you need to treat it with an oral agent. I talked about if you notice fungus on the hands, to ask about any pet guinea pigs, hamsters, or rats, because that's often the source. The child will hold a little critter in their hand and they'll commonly get fungus from it. And it's important for the animal to get treated too. Otherwise, the kiddo will just get it back again. And then I talked about the fact that kids get onychomycosis too. They get toenail fungus too. Certainly it's not as common as it is in the older patient population, but there's a misconception that kids don't get toenail fungus. They definitely do. And we can use terbinafine to treat it, or efinaconazole is approved down to the age of 6. Efinaconazole is a topical preparation that's applied once a day for a year. So that can be a little bit of a burden from a consistency perspective. I would say I typically treat with the oral terbinafine. I think it's the gold standard for the treatment of toenail fungus. I would say during that talk, I discussed the use of JAK inhibitors for alopecia areata and vitiligo. And we're all aware that JAK inhibitors have a boxed warning on them. And I think sometimes that makes people a little bit afraid. But I think what we need to do is take it as an opportunity to learn about the warning, learn where it came from, learn about what patient populations would be best suited for a JAK inhibitor, and maybe what patient populations wouldn't be well suited for treatment with that class of medicines. But to really embrace the warning and get really familiar with it and learn how to talk about it with your patients in a thorough but not scary way, because these medications offer so much hope for a brighter future for patients who are living with chronic autoimmune, really debilitating in some situations, conditions for which we have not had satisfactory treatment options prior to the arrival of our JAK inhibitors. And so these medicines are too dang good to be avoiding simply because of this boxed warning. We need to respect it. We need to learn about it. We need to prescribe appropriately. But we shouldn't be withholding these medicines from our patients who would benefit from them. We need to understand the warnings and be able to talk about it so that we can offer these therapies, because they're truly life-changing treatments.